I'd like to request Dr. Gaurav Shetty sir to conduct the next session.
So-
I'd like to request Dr. Suresh Babu Devanagari sir, the lead discussant for this session, to please come up on the dais and take a seat. I'd also like to request all the other panelists, Dr. Pavan Dara, Dr. Hari Mohan Meena, Dr. Manjunath Sharma, and Dr. Jagdish Dhenke to please come up on the stage. I hand over the session to the moderator, Dr. Gaurav Shetty sir.
Thank you. Good morning, everyone, and welcome to day 2. And we are here to discuss very, very important topic of pneumonia and what the conundrum is all about. We'll just discuss. And to discuss this topic, we have with us the lead discussant, a very senior Dr. Suresh Babu sir, who's a senior pediatrician at Bapuji Child Health Institute at Davangere, and next year, I believe, Respicon, we're going to Davangere, and he's held numerous posts, has been a former president of the Karnataka State IAP as well as the IAP Respiratory Chapter, and has numerous publications in international and national journals. We have a learned panel today to discuss this topic, and it's my pleasure to introduce Dr. Jagdish Dhenke sir, who is managing the Unique Children's Hospital at Pune and has been very active member of IAP NRC and has keen interest in pulmonology, infectious disease and vaccinology. Dr. Manjunath has been a leading light in IAP NRC for last couple of years, has been treasurer for IAP NRC and has been a key part of IAP Bengaluru chapter, and again has interests in pulmonology, allergy and asthma, and is a national faculty for ATM and has been a national faculty in past Respicons and has numerous publications. Dr. Pavan Dara is an associate professor at SPMC, Bikaner, Rajasthan, and is following his passion of pediatric pulmonology there and has 15 research publications to his name. Dr. Hari Mohan Meena again is from Rajasthan, from Dr. SN Medical College at Jodhpur, and he's practicing allergy and pediatric pulmonology and also has done diplomate in allergy, asthma and sleep medicine, and is the secretary of IAP Respiratory Chapter Rajasthan and has numerous publications. And I am Gaurav Sethi, I am from New Delhi, and I am the moderator for this session. And without further ado, I think we move on, because even though pneumonia may sound common and common sense, but there are a number of things which do add to the conundrum of diagnosing pneumonia, and I'd like our lead discussant to just introduce the topic to us.
Yeah, thank you, moderator Shetty. Pneumonia, basically we have a lot of confusions and difficulties. It may be a very simple pneumonia or it may be a challenging pneumonia. And of course, all of us know it's a leading cause of mortality. But there is no universal definition for pneumonia. But right back in 1985 or so, ARI control program was introduced by the IAP. And there, WHO has defined it basically on clinical findings, like increased respiratory rate and chest retraction. On this, they made the simple, like no pneumonia, pneumonia, severe pneumonia, and very severe pneumonia. This was the WHO definition. But pneumonia has, basically, it is the inflammation of the alveoli and this one. And LRTI is a combination. It may be a combination of bronchiolitis, it may be a combination of bronchopneumonia or a lobar pneumonia. And pneumonitis, it is not a term that is used nowadays. Anyway, they say that in some textbooks, pneumonitis has been described as the inflammation of the parenchyma. So we have varieties like lobar pneumonia, bronchopneumonia, interstitial pneumonia, basically is a viral pneumonia. And epidemiology, it is a very severe disease causing about 19% of deaths below 5 years and needing about 7 to 13% of hospitalization. And pneumonia, the next slide. What we encounter in pneumonia is, it may be a easily curable disease, as I said before, or it may be challenging, like in recurrent and persistent pneumonias, or it may be a difficult in case of immunodeficiency, pneumonias, and other conditions. So our plan of the presentation today is basically a clinical diagnosis of pneumonia, investigation where and when required, antibiotic issues, when to admit these children, when to refer these children, and complications and prevention of pneumonia. Now,
Thank you, sir. Thank you, sir. So we'll start with a case. This is Sahil, a 2-year-old boy who's weighing just 8.5 kgs, and he presents with high fever and cough of the past 3 days. He's running 102 degrees fever. The respiratory rate for this 2-year-old is 46 per minute, and on auscultation there are bilateral crepitations. The child is alert and responsive. So my question to Dr. Jagdish Dekhne sir is, does this look like a run-of-the-mill pneumonia or a usual pneumonia to you, and how would you diagnose pneumonia in day-to-day practice? Would you advise an X-ray for all patients where you suspect pneumonia, and any other investigations which we should be doing for pneumonia?
Essentially, pneumonia is a clinical diagnosis. We are all clinicians, and what we need to remember is we have to take a detailed history which will generally reveal that the patient has come with a predominant symptom of fever, and of course there is cough, but what is important is rapid excursions, which means tachypnea. The parents usually bring the child with tachypnea. There are chest restrictions and chest pain. And remember, when there is a child with predominant fever, mild cough, but has tachypnea, grunting, the diagnosis of pneumonia is more likely. When you see the child, you find that the child is sick, toxic, even if the fever has come down, and there is grunting, nasal flaring, chest retraction, and hypoxia. And this makes the diagnosis more or less certain clinically. Fast breathing is very important for us because that is the important cardinal clinical sign. And let me tell you that most of us do not take the respiratory rate for as long as 1 minute. And if you take the respiratory for more than 1 minute, just take the age of the child into account. A respirator of more than 40 in a child between 1 to 5 years of age, more than 30 in a child after 5 years of age, and breathing which is around 50 in a child between 2 months to 1 year of age will make a diagnosis of pneumonia. So fast breathing with the respirator more than 50, more than 40, more than 30, depending on the age, is the most important cardinal clinical sign to make a diagnosis of pneumonia.
Sir, as you rightly said, many of us don't take the respiratory rate, or even the patient may not allow, like a patient who's undergoing vaccination at my clinic, as soon as he sees me, already the respiration becomes fast. How are we going to pick up pneumonia in a child who's already apprehensive and tachypneic and tachycardia is there just by looking at my face?
See, examination of children is difficult. You make them calm down in the lap of the mother, breastfeed the child if the child is less than 1 year of age, and generally if you observe the child for a little longer time, have some patience, and take the respiratory rate for more than 1 minute on a few occasions, you will definitely be able to pick up pneumonia. Because remember, tachypnea is the most important cardinal clinical sign which you need to pick up. So it is challenging, of course, difficult in children because examination in children, especially irritable, is difficult. And hemogram, X-ray chest, and CRP may not be required in each and every person, but usually it is done when pneumonia is suspected. And an X-ray, which is done in the child who comes with predominant fever, cough, grunting, and if you add an X-ray, your diagnosis becomes more or less certain. Now remember, it is not needed in every child, but a child who is acutely worsening in your clinic, there is a poor response to treatment, there are recurrent persistent symptoms, you are suspecting complications, and there is a suspicion of a chronic disease, X-ray is a must. So it's not required in every child, but it is definitely required in a few conditions when there is worsening, poor response to treatment, recurrent persistent infections, and when you suspect complications.
So for this patient, you would diagnose him as pneumonia as per the... So if this clinical picture is very common in our day-to-day practice, but why don't I see prescriptions with pneumonia written on them? I see prescriptions of ARI, ALR, TI, but hardly ever do I see a prescription which says pneumonia. Are we apprehensive of calling pneumonia, just like asthma? We don't want to say asthma, we don't want to say pneumonia.
I think we failed to take the respiratory rate. See, you have written the respiratory rate is 46 in a child who is 2 years of age, And a pneumonia, clinical pneumonia, community-acquired pneumonia, all means the same, but I think it's important for us to make or pen down your diagnosis, and that you've taken the respiratory rate of a child, particularly when the child has become afebrile with the antipyretic dose you have given in the clinic.
So once the child is afebrile and a little calmer, realizes that you're not going to do any harm to the child and is breathing at a normal rate, like not apprehensive, then thank you, sir. So Dr. Pavan, if this same child, also there was a history of a runny nose for the past 4 to 5 days, and I on auscultation also found a wheeze, would your diagnosis change in this child? So what I'm getting at is, what are the usual pneumonia mimics that we may be seeing or missing in our daily practice, and how would you distinguish bacterial from viral pneumonia?
So, as earlier said, pneumonia is difficult to diagnosis as well by counting respiratory rate, or it is always difficult to differentiate between pneumonia mimics. Common are bacterial pneumonia, viral pneumonia, atypical pneumonia, but some clues are there to suggest or to help us. Like in viral pneumonia, there is initial history of upper respiratory tract infection, there is mild fever. In bacterial pneumonia, patient baby is looking toxic, high-grade fever, and chest pain may be in lobar pneumonia. So some clues are in there in symptoms. Then we can go for laboratory tests. In bacterial pneumonia, there is neutrophilic leukocytosis there. Viral, in viral, there is lymphocytic predominance, but it is not as such clear-cut as usually.
So there's a lot of overlap between the viral and bacterial
overlap,
in the
and
CBC
patient
as well.
already come with certain antibiotic taken from already any RMP or in medical chemist. So it alter picture. Then we go for chest X-ray. In chest X-ray, viral pneumonia, there is the diffuse infiltrate, paratracheal, parabronchial, and it is usually symmetrical. In bacterial pneumonia, there is usually unilateral, or there in periphery there is certain consolidation. So in this X-ray with in pneumococcal there is the lobar pneumonia, and in lower zone there is homogeneous
So
opacity.
even if we do make a clinical diagnosis of viral pneumonia, does it change our management? Would you still write an antibiotic for a child with suspected viral pneumonia?
So sir, it is difficult to differentiate.
Yes.
So, and this is the one of the leading cause of mortality. As per
Sure.
WHO, 2/3 of the bacterial pneumonia are not received antibiotic. So we have to start antibiotic.
So
at least
even if we
regularly.
do suspect viral pneumonia, we are bound to be writing an antibiotic at least.
Yes.
And what about atypical pneumonia? We keep hearing a lot about atypical pneumonia. You've told us already about how to differentiate viral and bacterial pneumonia. Any clues for atypical
Sir,
pneumonia?
atypical pneumonia, it is looks like viral pneumonia, and wheezing may be there, and patient not sick, so it is called walking pneumonia. And usually diffuse lung involvement, usually multi-system involvement, and is usually more than 5 years, but it in now onwards we see in 3 months or 6 months also. Sometimes.
So in atypical pneumonia, basically it will be a more prolonged smoldering kind of course. There will be more symptoms, lesser signs. The child will be less toxic, and maybe you could find a conjunctivitis, which could be viral or it could be pointing towards chlamydia. But atypical, they're not, as he rightly said, walking pneumonia. They're not as sick, but they have pneumonia. So I think, as Dr. Pavan mentioned, that a lobar consolidation with high fever and a large effusion, definitely you're suspecting a bacterial. So coming back to our case, we took a further detailed history and we found that the child had received insufficient breastfeeding as well and was on diluted milk and was unvaccinated, was pale. The counts were done, the X-ray was done, there's a right lower lobe consolidation, the counts were high with neutrophilia, but the diagnosis made was community-acquired pneumonia. So my question to Dr. Manjunath is that in such a case, do we need to assess severity first of all, and how do we assess severity in these patients?
We should be assessing the severity, that is to have the prognostication, how severe the disease can go. So there are no absolute clinical criteria to say what is a very severe or a severe pneumonia. It is based purely on the clinical judgment. You know, we have the general danger signs for us to say whether it is a very severe or a severe pneumonia. Not able to drink or feed, persistent vomiting, convulsions, cyanosis, lethargic unconsciousness. Stridor in a calm child is a very dangerous sign. We need to keep that in mind. And of course, as we have known from the epidemiology of the asthma of pneumonia, we know that severe malnourishment can cause very severe pneumonias. So these are the measures by which we can assess the severity of pneumonia.
Yeah, so unlike the previous session, which was pretty high-tech, here we need to use our higher functions more, and
It is
this is all
purely
clinical
based on
judgment
the
that you
clinical
can...
judgment. You look at the child, you look at how the activity of the child is, how
Because the
toxic
investigation
looking
will
the
not
child
help
is.
you that much, it's more on the clinical
Yes,
judgment here.
you look at the child and make a decision. That's more important.
Sure, thank you. And sir, can we take the questions at the end? Otherwise, I'm sorry.
Yes. It's a indication that we are looking at very severe disease. It is going for a very severe disease.
So his point, sir, your point is well taken. It could be a croup, it could be a viral infection that could cause a stridor, and we should have qualified it more. So going further, what would be your indications for hospitalizing a child like this, or even a PICU transfer, if I may ask?
See, once we start looking at the child, when we have started assessing the child, triaging that child is very important to make a differentiation whether this child can go home or to the hospital or to the PICU. So whenever any child, whenever you make a clinical assessment, whether it is going for a moderate or a severe community-acquired pneumonia, that child needs to go to hospital. Any child who is less than 3 or 6 months, that child can also go for a very severe pneumonia owing to its age, owing to its immunity factors. That child can also go very sick. So that child may also need admission. And whenever we suspect a very virulent organism like a Staph aureus or a MRSA, it's very difficult to make on the clinical assessment, but we need to have very strong intuition. Whenever we think of very severe disease, just admit that child and make sure the child gets the antibiotic intravenous. That's purely again a clinical assessment. And whenever you see a child in an OPD basis, you're not sure whether the child gets the proper treatment, and the compliance is not very assured
Especially
in those
in
children.
the peripheries and in the...
In a less affluent children, or the parents are not very well educated, not very organized families. So even those children may need hospitalization.
Sure. And what about PICU transfer? Which children would you qualify for ICU?
See, any child who is already on any non-invasive ventilation like HFNC, or when the child is already on endotracheal intubation, that child straight away has to go to ICUs without any second thought. So, the international, IDSA guidelines specifically say that, there is a very strong recommendation, and the quality of recommendation is also very high, that whenever any child is intubated, that child straight away has to go to PICU. And whenever there is any impending respiratory failure, even that child has to straight go to PICU without any second thought. So if the child has sustained tachycardia, where the perfusion is not good, unstable blood pressures, even that child should go to PICU. And if you see the child is not maintaining the saturations, you put the oxygen, you go on increasing the oxygen even after 50% of the FiO2, the saturations are not really well maintained. Even that child is better off in PICU than in the ward or the any other place. So it is not just one criteria. We have to take the constellation
Sure.
of all these signs and symptoms to make a decision whether this child should be going to the ward or PICU.
So the younger the child, the sicker the child, you may have a serious morbidity or even mortality on your hands, so be careful. And so we move on. And I'd like to ask Dr. Hari Mohan, how do we choose antibiotics? Because there's a lot of antibiotic resistance now. There's a huge campaign by IAP as well to reduce the antibiotic prescription. And we've already said that any case you're suspecting pneumonia, even if you feel that it's a viral pneumonia, we are bound to start antibiotics. How do we choose antibiotics?
As far as the antibiotics management of pneumonia is concerned, first of all, we have to see whenever you are dealing the pneumonic child, you must know what is the age. That is very important to assess the offending organism. Number one, you must assess the severity of the pneumonia because it indicates the prognosis of pneumonias. Third one, you have to assess whether it is the pneumonia with or without the complications. So, fever, cough and tachypnea is pneumonia, but must rule out the differential diagnosis because first, whenever you start the treatment, you must know the confirmed diagnosis. Once you made the diagnosis, you have to assess all those things I have said. Now you have to decide. In case the community acquired pneumonia, if age is less than 3 months, you have to hospitalize each and every child because you have to consider it as the severe pneumonia. There is no domiciliary management of less than 3 months. If age is 3 months to 5 years, the drug of choice is first line is amoxicillin. If age is more than 5 years, still is the drug of choice in case of community acquired pneumonia is the amoxicillin as the first line. In case of the second line, 3 months to 5 years, second line you can have amoxicillin or cefuroxime. In more than 5 years of age group, if amoxicillin is not working, you can add the azithromycin or levofloxacin.
Sir, what dose of amoxicillin? You've said amoxicillin as the first line. What dose of amoxicillin are we supposed to prescribe? There's a lot of talk about high dose amoxicillin these days. There's a lot of pharma pressure as well on using the higher dose formulations.
As the prevalence of the penicillin resistant pneumococcus is very, very less in the Indian subcontinent. So dose of amoxicillin in the Indian subcontinent is 40 to 50 mg per kg in 2 divided doses. If it is prevalence is high in like the European countries, the
In
dose
3 divided
should be-
doses, you mean? 8 hourly.
2 divided doses are sufficient. 40 to 50 mg per kg.
Correct
2
me
divided
if I'm
doses are
wrong, but
sufficient.
for pneumonia, I think we advise 8 hourly. For tonsillitis, we are within our rights to prescribe 12 hourly, but for pneumonia, 8 hourly would be a better choice, I believe. So the message is clear that we are not using high-dose amoxicillin in India as of now. And if there is penicillin hypersensitivity, please go on.
Suppose a child is having penicillin hypersensitivity reactions, then you go for this cefodoxime. If it's type 1 hypersensitivity reaction, it can lead to the anaphylaxis. Now in this case, you can go for the levofloxacin and clindamycin or macrolides.
And
In case of
what
once you
macrolide,
decide
sir?
once you decide the severity of pneumonia, if there is
Sir, what macrolide for the, which one would you choose?
azithromycin is preferred macrolides in case of pneumonia.
In what dose and for what duration?
In each first day, you have to give the 10 mg per kg. Then you can give the 5 to 10 mg per kg for 5 days. In case of the severe pneumonia, because the morbidity and mortality is high, so you have to give the parenteral antibiotics. If you see the other indication of the parenteral antibiotics in case of pneumonia, the age is less than 3 months, you have to give the cefodoxime or ceftriaxone. More than 3 months of age, you can give the ampicillin. But ampicillin is only indicated where your child is not so sick. It is well immunized for the H. influenzae and pneumococcus as well. You can give the ampicillin. But if it's not immunized, you are not sure child is so sick, you should go for the ceftriaxone as the first line in the more than 3 months of age group. If you are suspecting the Staphylococcus aureus in terms of rapid onset of the pneumonias, fulminating course, child is so sick, presence of nematoceles. In this case, you should go for the vancomycin as well.
So, our case, you've already seen the case history. Your choice of antibiotic for this patient, sir.
So this is the most likely case of this is the lower pneumonia, seems to be non-complicated case. So the best drug of this case is ceftriaxone because this is case of the severe pneumonia.
This child should go in the hospital and on ceftriaxone, you believe?
Yes, this should be
This
hospitalized.
child is
because
alert, active, playful, has a pneumonia, but anybody else want? Dr. Dhekne, sir, what would you do
If a
with this
child is not so sick and is it not severe pneumonia, you go for the amoxicillin as well.
So in private practice, Dr. Dhekne, sir, do you see prescriptions of amoxicillin these days? Because in Delhi, when we take RTI GEM or some other module, people usually ask me, sir, amoxicillin plain milta bhi hai aajkal? And I say, yeah, milta hai. We are writing it every day, but most people would ask that question.
I think we need to monitor the patient. We can treat these patients on OPD basis, but it's a little risky because the child has already got tachypnea. You can give this patient amoxicillin alone, and that will probably work, but requires a lot of interaction with the parents, and if they can monitor the patient at home, it's fine. Otherwise, you admit this patient, and you can also give amoxiclavulinic acid if amoxicillin has been already received by the patient.
Yeah.
Otherwise, the safest would be to start the patient on IV ceftriaxone if you find that the parents may not be able to monitor this patient at home.
So the
And that is
message
what
is
most
that
of the pediatrics would do
in
it.
a run-of-the-mill usual pneumonia, community-acquired pneumonia, we can and should be treating with amoxicillin, and it still works. We are using it for tonsillitis. Most of the otitis media also responds. Tonsillitis responds beautifully even at twice-a-day dose. Amoxicillin still works in most cases, and we should not shy away. But another thing which we should check is that whether the child has received a co-amoxiclav kind of antibiotic in the past 1 month or so. If the child has received a high-end antibiotic recently, then writing amoxicillin might be a bit.
And most of that patients have received before, that's the experience.
So, continuing with you, sir, what would be the recommended duration of treatment and how would we monitor response in these children?
Monitoring of the patient is entirely clinical, and remember that we can treat patients on OPD basis, especially when they are non-severe, and as much as 7 days would be good enough. Generally, the patient remain afebrile for about 5 to 7 days after you have started the antibiotic. So the antibiotic duration should be for at least 5 days after the patient has become afebrile. But when you find that the patient has a staphylococcal disease or a complicated pneumonia, the patient is admitted and parenteral antibiotics may be required for as long as 2 to 6 weeks. In complicated pneumonias with empymas, as long as 6 weeks of antibiotics are generally required. So remember, the patient needs to be given antibiotics in complicated staphylococcal pneumonias parenterally. However, on OPD basis, you could treat them for about 5 to 7 days. Yeah. Depending on the age, the time at which that child achieved effervescence in the form of clinical improvement and no fever, and generally a dose of 5 to 7 on OPD basis can be all right in a patient who is not immunocompromised or having good immune system.
Sure, sir. So contrary to the recommendations for tonsillitis and otitis media, where at least 10 days antibiotic has to be prescribed in pneumonia, 5 to 7 days, 7 days on the safer side, I think should be enough for most of our patients. So monitoring of response, sir has already touched on, but please continue.
Child looks, the fever comes down, the child looks better, sleeps well, urine output increases, there is rapid downfall of, tachypnea, respiratory comes down, the tachycardia comes down, and the OT requirement comes down rapidly. And clinical improvement is far more important than radiological improvement, because there is no point in doing repeated X-rays when the patient is doing well clinically.
And what if the child does not respond, sir?
Does not respond. The first thing that you see if the patient is on OPD basis, check the compliance. Very often in pediatrics, you might write the prescription, but the mother comes and tells you that my child is vomiting everything that you give. So checking the compliance in a patient not responding is extremely important in OPD practice. However, if you find that the compliance is good, suspect complications. The earlier you suspect, the better the results. They can be pulmonary, they can be extrapulmonary. And we go to the next slide to tell you.
So another thing, if you are using co-amoxiclav, please confirm whether they have refrigerated it. If it's outside the refrigerator, within 24 to 48 hours, the clav part gets denatured, and you can ask the parent also. When they reconstituted it, it was crystalline white, and in a couple of days it becomes absolutely yellow, creamish. It is not going to work as well. So that has also been seen many a times that it won't work. So coming to Dr. Pavan, sir, as Dr. Dhekne sir said that if the child is not responding, we need to suspect complications. So what complications do we have to look out for in pneumonia?
Sir, complication may be spread by direct or maybe hematological spread. There may be the pleural effusion, empyema, pericarditis, and meningitis, endocarditis, suppurative arthritis, and osteomyelitis.
Sure, sir. Thank you. Dr. Babu, sir, anything that we have missed in the management of, or the diagnosis and management of community-acquired pneumonia?
Yeah, everything was discussed by all our panelists very nicely, and basically we have covered what is a community-acquired pneumonia, how they present clinically. It is basically a clinical diagnosis, and how to assess these children, when to admit these children, when to investigate these children, and what are the important antibiotics, whatever first line antibiotics, second line, and when to know the complications, when to suspect the complications. All these things have been discussed very well. And one thing is we have to keep these children. As you said, amoxicillin, they lose their potency if it is refrigerated. But how many of our families will have a refrigerator? That is so there are tablets available. So you can always, dispersible tablets available.
Definitely.
That can be prescribed if you are sending the child home for domiciliary treatment.
Sure, sir. Thank you, sir. So coming back to Dr. Manjunath, moving on to hospital-acquired pneumonia now. So we've been through with the community-acquired. How do we define or categorize hospital-acquired pneumonias, and how do we choose antibiotics for the same?
No, as per the IDSA guidelines and many other guidelines which I went through.
The mic, sir.
As per the many guidelines which I went through, the definition is very clear. Pneumonia that occurs beyond 48 hours of hospitalization, and in which a child
I'm sorry, I'm interrupting you. Was this different earlier? There was a 4-day, 3-day thing?
There was this doubt whether it's 4 days or 2 days, but now I think it's 48 hours
48
is a reasonable time.
So there's been a change over the years. Please note that it's 48 hours now.
Yeah. Now, which was not incubating at the time of admission. That is considered as the hospital-acquired pneumonia. So we need to see, any child who has been admitted develops the signs and symptoms of pneumonia. We may have the clinical criteria as what's been discussed, the tachypnea, cough, and fever, and the lung infiltrates which have newly onset, and the laboratory investigations when you draw the blood samples and you see that the counts have been increasing, the inflammatory markers like procalcitonin or the CRP are increasing. That's when we make a diagnosis of the hospital-acquired pneumonia.
Sure.
The
Common pathogens that
yeah, of course, there are multiple ways why the hospital-acquired pneumonias can happen. And the HAPs or the ventilator-associated pneumonias, they all have different pathogens. The most common would be still the gram-negative bacilli, which could be Pseudomonas, E. coli, Klebsiella, Enterobacterus, and the Enterobacteriaceae, and
and would depend on the hospital flora.
Yeah, whatever the hospital flora is. So those are the most common bacteria which are likely to get affected in that children. And to have a prognostication, these HAPs have been divided into less than 1 year and beyond 1 year, only for the severity of the illness in children less than 1 year. The disease can go very severe. For that reason, it's categorized into under 1 year and beyond 1 year. So that's how we make the categorization.
Sure. And any suggested treatment for this? Is it different for hospital-acquired versus community-acquired?
So in the community-acquired pneumonias, the first choice is, of course, the amoxicillin oral. But in a case of hospital-acquired pneumonia, it is always considered as a severe pneumonia, and we need to start with a aminoglycoside. Whichever is available, preferably would be amikacin, which is easily available. So we need to target the bacteria which we already discussed. So we need to give the aminoglycoside plus other antibiotic, which could be piptaz, meropenem, or ceftazidime or cefepime. And clindamycin can be considered in case of type 1 hypersensitivity to beta-lactam antibiotics. And vancomycin, whenever we suspect a MRSA, so vancomycin is preferable for those kind of bugs.
Sure. Dr. Harimon, sir, is ventilator-associated pneumonia different from hospital-acquired pneumonia, or should we approach it as the same?
Yes, the ventilator-associated pneumonia is the entirely different as compared to community-acquired pneumonia in the various ways. This ventilator-associated pneumonia is basically one of the type of the hospital-acquired pneumonias. You know that there the organisms are absolutely different, or you can say the majority of organisms are different as compared to community-acquired pneumonias. As far as the cost of this management of this pneumonia is concerned, because it is a severe kind of pneumonia, the increase of the hospitalization stay, ventilation requirement, as well as the other medication and the investigation requirements and increase, so cost of management is also increased. As far as the management is concerned, every hospital should have the antibiotics policy based on the culture reports, because each and every PICUs can have the different kind of the flora. In case of the if a hospital policy is available, the specific antibiotics can be started as far as this ventilator-associated pneumonia is concerned. If it is no hospital policy is available, we have to manage that, we have to cover the all possible organism. So we have to start the piperacillin tazobactam plus amikacin with or without the vancomycin, or you can replace you must have these anti-pseudomonal antibiotics to cover these organisms.
Sure. So it's not just practicing and having a inpatient. We must always audit ourselves, have introspection, see what we are dealing with, and have certain, let's say, a board which meets and kind of decides what are we encountering, and we should know what all bugs are there in our milieu.
So these are the different doses of the antibiotics in case the BAF. The duration of your antibiotics is usually 7 to 14 days.
Instead of the 5 to 7 days, the ventilator-associated pneumonia at least would require 2 weeks of therapy, and these are the higher end, so to say, antibiotics that we would end up always using.
Yeah. Yes, sir.
So moving on, I think we'll just hurry it up because we have a very interesting case.
Case 2, you can go.
So the next case is again a 2.5-year-old girl who's having recurrent episodes of fever, cough, and fast breathing, and has already been admitted 3 times in the past 6 to 7 months. Although the first 2 years of her life were quite uneventful, there's no history of any frequent wheezing, nebulization, or frequent antibiotic use. There's no history of contact with TB, no choking episodes, no measles-like illness. There are no other signs of other system involvement. There are no diarrheas, no recurrent ear, skin, or soft tissue infections, no sinus infections. So in this kind of a scenario, where these are the x-rays from the previous 3 hospitalizations, where we can see right lower lobe pneumonia, there's a right lingular shadow, and then there's a left upper lobe pneumonia that she has already had in the past 6 months. Otherwise growing well, there's no clubbing, there's no significant pallor, there are no other system involvement, as I've already said. So Dr. Dhekne sir, how would we differentiate recurrent pneumonia from a persistent pneumonia? Because both of them sometimes cause some conundrum in the practitioner's mind.
See, what is persistent pneumonia is you have treated the patient, and a small proportion of them, despite of the best of treatment, having checked the compliance, continue to have symptoms beyond 1 month, and there is a radiological abnormality. But what is most important is they have clinical symptoms in spite of the best of treatment. And these are a small number of patients. And if this persists for more than a month, you said that this pneumonia is a persistent pneumonia. In recurrent pneumonia, what you really have is the symptoms and has completely cleared. There is a complete radiological resolution, but is a reoccurrence of symptoms. And when this occurs for more than twice in 6 months or 3 months, 3 times in any lifetime, it is called as recurrent pneumonias. Sure. Please remember that 2 episodes in 1 year or 3 episodes at any time frame is very important for recurrent pneumonias. When you suspect recurrent and persistent pneumonias, first important thing is find out whether the recurrent respiratory infections are lower respiratory. Now, this is again very important because you get a lot of patients who have not some low respiratory tract infection. So, before investigating a
Yeah, so
child,
patient themselves come and say कि बार-बार pneumonia होता है सर
हाँ
इसका.
वही तो होता है. And then that's very important for us to clinically confirm that these are definite lower respiratory tract infections. And remember, these are not watertight compartments. Generally, the approach for both these types of pneumonias is clinical, and the investigations are more or less on the same lines, depending on the detailed history. And you need to understand whether there have been interval symptoms in between. For that, you have to take the history each time and every time that the patient is seen by you.
So unlike the initial community-acquired pneumonia where we were discouraging use of the radiology, here definitely radiology is required. There should be radiological clearance as well as asymptomatic periods in between. So Dr. Pavan, what are the usual causes of recurrent pneumonia now that we've decided that this case looks like a recurrent pneumonia, the child improves, then gets a different lobe is getting involved. How would we approach this kind of case? How would we decide which investigations to do?
So, causes of recurrent pneumonia may be due to congenital malformation. It may be at the level of airways, it may be at the lungs, or it may be the cause of CVS. We don't forget that CVS may be causes of recurrent pneumonia, and then aspirations, it may be GRD or maybe foreign body. Then defect in clearance of the airway secretions, that is cystic fibrosis, and disorder of systemic immunity, it may be primary or it may be secondary.
So congenital malformations, aspiration syndromes, there are ciliary disorders, but Dr. Pavan has made a very nice flowchart which everybody can use in day-to-day practice. Please go ahead, sir.
So, as earlier said, and we know that history is most important. So, take detailed history, physical examination. We have to revise our history also because this is the case of recurrent pneumonia. If we all collect previous X-rays and other immunization also, so by this we can rule out tuberculosis, foreign body, or aspiration, and it may be as per earlier slide, it may be difficulty in feeding, coughing or choking during feed. So we go for GR study, and if infection in other part of the body, we rule out immunodeficiencies, primary and secondary maybe, and associated malabsorption is there, and pseudomonas in the airways, we go for sweet chloride and mutation for cystic fibrosis, and no clues from history and examination, then we go for rule out congenital airway malformations by bronchoscopy, CT.
So the message is very clear. In our country, first and foremost, we rule out TB. And in small age group, foreign body, definitely rule out. And then you take these very simple pointers that he has given in history, that you look for the feeding difficulties, the aspirations, and then look at the other parts of the body if the child is getting repeated. Like many patients will come to you, sir, iski immunity bahut kam hai. So first and foremost, you ask, has this child had pneumonia, dysentery, pus from the ear? So 3 different things coming from different systems. So, and once we do kind of what investigations would we have as a thumb rule, like these would be the imaging, the swallowing studies, bronchoscopy you've already mentioned, and GER and sweat chloride. So once we have a diagnosis of recurrent pneumonia, how do we go ahead?
So if recurrent pneumonia, we should look for it is unilobar or multilobar. If multilobar, check for immunity, and recurrent pneumonia with immunodeficiency, it may be congenital or acquired, and recurrent pneumonia with normal immunity, it may be due to structural abnormalities, or it may be aspiration, it may be the post-infectious bronchitis, mucociliary disease, and heart failure by secondary to asymptomatic CSD.
And for the unilobar?
If unilobar or localized pneumonia, it may be at the narrowed airway. It narrowed airway at the airway extrinsic compression by lymph node, neoplasm, vascular ring, or it may be the bronchial wall, bronchomalacia, laryngeal wave, strictures, and endobronchial foreign body tuberculosis and by neoplasm. And congenital may be lung lesions, benign lung cysts and sequestrations, and focal bronchitis. So,
Thank you. You made it really simple. So coming back to our case, this was the history that we took, and these are the x-rays that we had. So we worked up this case, and there was, at every admission, there was neutrophilic leukocytosis. The TB workup was done extensively. GAs were done. Everything was negative. Echo was normal. The immunodeficiency panels were all negative. Sweat chloride was negative. This is the current x-ray on the 4th hospitalization. So it's again, a different lobe is involved again. So a CT was done, and there was some bronchiectasis, volume loss, and there were reactive mediastinal lymph nodes. And then bronchoscopy was done. And Dr. Babu sir, would you like to describe this bronchoscopy?
Yeah, this child was subjected for bronchoscopy, considering the different lobe involvements at different times. And this child was, now you can see that we are entering into the trachea and slowly going towards the bronchus. And to our surprise, we saw, you can see now it pops out just at the bifurcation.
So all eyes on screen, please. This is a
You can
beautiful-
see that is the thing which was causing problem. It was a peanut embedded with all this stuff, and it was moving from one side to the other, jumping from one side. So this is called as a mobile foreign body, which can infect different lobes at different times. So this was a case of...
This is almost like on command that the peanut is popping out, jumping from one
Yeah, because
side
it was
to the other to
surrounded by
show
the
you,
slough.
boss, I can do this.
So it was just like jumping to different
So there were
lobes.
2 pieces of peanut in this child, and that was causing the recurrent pneumonia due to the migratory foreign body. So that was a beautiful case from Dr. Babu sir. Thank you. So going on, Dr. Manjunath, what conditions can masquerade recurrent pneumonia? Like we might just keep, there would be some conditions which would look like recurrent pneumonia, but
Yeah,
are not.
there are so many conditions, which they may appear as pneumonia, they present as pneumonia, but underlying problems might be much different. That's what the entire masquerade word means. Once you take an X-ray and if you find a prominent thymus, we think that could be again a pneumonia. A prominent breast shadow or a bronchogenic cyst or a vascular cyst. Or these sequestration syndromes or CLEs, they appear as pneumonias, but they actually are not. So we need to have a very astute mind to see whether it is just a pneumonia or something else which is mimicking as pneumonia. So we need to have a very good history and at the same time a good clinical examination along corroboratively with those X-rays we can identify whether it is just a masquerade or a true pneumonia.
So I think
There
in
are
our practice, the most common thing would be a thymus in the younger children.
Yes.
And in our asthmatic patients, we do get mucus plugs causing
Yeah, there are mucus plugs
temporary
which can
collapse.
also present as that.
Yeah.
And some of the aspiration syndromes, they come to us with repeated pneumonias, but then those tracheoesophageal fistulas, but the underlying problem is something else.
Yeah.
So we need to have a very open-mindedness to look at these things. And many of the neuromuscular disorders, they actually present as pneumonias, but it is the inability to cough out those bacteria. That's the reason why they get pneumonias.
Thank you. So, Dr. Babu sir, can you just conclude the entire presentation that we've had on pneumonia, sir?
Yeah, just I'll be summarizing whatever we have discussed. Pneumonia may be very simple. Treat it and let the child go home. Everything is cured. Or it may be challenged. That is usually happens in community acquired pneumonias. Sometimes they may pose a problem. And then challenging, it can be challenging, especially in recurrent and persistent pneumonias. One time we may not be able to diagnose. Many times the child will come with different. So these are the cases where they need a lot of investigations, challenging to us. And difficult pneumonias are the hospital and ventilator pneumonias, because here we need a good bacteriological backup. for this, and hospital should have a policy. So community acquired pneumonia is basically a clinical diagnosis that has been discussed. Choose the appropriate antibiotics for the age. At different ages, different antibiotics should be suspected, should be chosen, and investigate if relevant. All community acquired pneumonias may not need investigation. Only in special conditions, as discussed before, we need to have investigations. Relapse or non-response to the antibiotics, consider complications. Especially you are given antibiotics for a few days, the child will go back to fever, go back to respiratory distress. You suspect a complication, especially parapneumonic effusions. Clinical response is more important than radiological. So when a child is clinically improving, don't do another X-ray for knowing the clinical aspects. And know when to investigate, when to refer, when to admit, and when to identify the comorbidities. Comorbidities you have to keep in mind. Congenital heart diseases and other comorbid conditions in the child, you have to keep that in mind. Hospital-acquired pneumonia, if it is 48 to 96 hours, usually the community-acquired pneumonia bugs will be the causative origin. More than 96 hours, it is the hospital bugs. So here, we need basically the investigation. HAP and VAP, culture always helps. We had to do cultures, especially the ventilator-related infections. We had to do the cultures, and hospital should have a policy. Recurrent pneumonia, one lobe, consider anatomical defects, especially in small infants. Different lobes, consider physiological, or it may be a biochemical. So all these considerations we have to do depending on which lobe is involved and whether it is one lobe or different lobes. Document the clinical and radiological clearance in recurrent pneumonias. You have to do that. If you are having a case of more than 3 attacks, so you have to do repeated radiological examination. Aspiration likely in CNS disorders, cleft lip, palate, and GERDs. Radiologist must be your best friend. Discuss, because lateral views sometimes, if you cannot do CT, if they are poor, lateral views definitely helps to know what is the mediastinum, what are the different lobes. So that will help. So lateral views is a poor man's CT. Suspect mimics when clinical history does not correlate with signs and symptoms. And no anti-tubercular drugs without proper investigation. Many times you are tempted, especially in recurrent pneumonias, tempted to give anti-tubercular drugs. Never do that unless you properly investigate, prove the diagnosis for tuberculosis. A good history, a careful examination at every visit. Every visit, the child must undergo a good examination, and which is very essential in the management of pneumonia in children. And prevention is the need of the hour. We have a lot of respiratory vaccines that you have to prevent these pneumonias, and cleanliness, hand washing, and all these things to go a long way in prevention of pneumonias.
Thank you, sir. So, as a mark of our thanks to the organizers, we finished well within time. And it's been a pleasure being moderator for a wonderful and very, very enlightening session from the panelists. I'm thankful to all the panelists and to our lead discussant. And I'm also thankful to Dr. Vineet Sehgal, sir, for helping me plan this panel discussion. And now we're open for questions.
Sir, in the antibiotic page, you have mentioned moxifloxacin and levofloxacin, and it is actually a reserved drug for MDR-TB. And how do you consider this drug in treatment of pneumonia?
Dr. Harimohan, you're asking about levofloxacin.
There are two, levofloxacin and moxifloxacin mentioned.
Levofloxacin and?
Moxifloxacin. Both are mentioned in the treatment.
Yes. These are recommended as the age of the child is more than 5 years. It is the second line of the therapies. If the first line therapy is not working, you can switch over to the more than 5 year of age group. That is levoflox or moxifloxacin. The preferred one is the levofloxacin. As the dose is 10 to 20 mg per kg in the single dose.
No, sir. My question was that
He's asking, they are reserved drugs for TB. Are we justified using them for pneumonia?
That's why they are not commonly recommended for each and every child, where they only the selected cases. That's why even the lineage already they also reserved for the tuberculosis. But even the selected cases, those are not responding to the conventional therapy, then you can add, otherwise not routinely not recommended.
So most of our patients would respond to amoxicillin or amoxiclavulinate. That is the message that we want to send out from this panel.
And also
the
there-
other drugs mentioned are reserved drugs for very few
Yes,
patients.
sir. They are
Sir,
the
I
reserved
think
drugs.
sir is waiting.
Yeah, just my thoughts on recurrent pneumonia. I think in our country, vast majority of cases of bronchial asthma are actually being treated for recurrent pneumonia.
Definitely.
This is one. But my question to the panelists are that what is your say on ultrasound as an investigative tool? I'm like, because of its safety profile, can it actually replace X-ray in the days to come? And how sensitive it is?
Anybody wants to take that?
Ultrasound is helpful in the case of detecting the pleural area, especially pleural effusions. And sometimes you can see the mediastinum. That's the ultrasound. Usually we use ultrasound in the diagnosis of suspected effusions, parapneumonic effusions, to see that. And ultrasound guided treatment also we give. So that is the helpfulness of ultrasound.
So it is an upcoming tool, and if we see Dr. Dhiren's presentations, then he's using ultrasound for many conditions. But I think we are learning on the job, and maybe in the future. But that video that's been going around on WhatsApp for quite a few years, where the doctor is leaving the stethoscope and just using the ultrasound, we're not there yet, and I don't think we'll be getting there. The stethoscope will continue to be important. Yes, sir.
Gauravji,
Yes, sir.
for ultrasound versus chest X-ray in pneumonia, please refer to the first article published in our own respiratory chapter, Pediatric Pulmonology Journal, from one of the studies in our institution, which won the best paper award in the last Respicon. Please refer to that article. At least you will visit our journal also. So it will serve both the purposes.
Sir,
answers are there.
the issue of antibiotic stewardship in pneumonia, particularly wherever you suspect a viral pneumonia where there is bilateral wheeze, in which condition you will not use antibiotic, because that is a very common thing. You get a child with respiratory distress, bilateral wheeze. So bilateral signs in a child, that rules out bacterial cause. So do you need to give antibiotic in all children having signs of upper respiratory infection and then he's got a distress and bilateral wheeze?
No, sir. We should not be using antibiotics in those cases. But if we get an X-ray and that X-ray shows a pneumonia, even though we are suspecting viral pneumonia, then we should be giving antibiotics. I think everybody agrees on that.
So the PERCH study which was done, which clearly says that at least 60% of all the pneumonias are viral. We need to be very diligent in our antibiotic prescriptions. Whenever we strongly suspect a bacterial pneumonia, we need to start. Sometimes...
No. My question is not bacterial, it's very clear. More common is a child with a healthy child, mild distress, bilateral wheeze. So that is not, because if you see the definition of WHO, fever, cough and distress, you give antibiotics. So that is not for doctor, that is for other people.
Sir, your point is well taken. The message that we were trying to give was not this. If a child is coming with bilateral wheeze, a runny nose, let's say, a viral induced wheeze, whatever, we are not labeling him as viral pneumonia, we're calling him a wheeze-associated lower respiratory infection and treating without antibiotics. But even in that patient, if we get an X-ray and that X-ray shows a pneumonia, then we have to write an antibiotic.
I can add.
No, sir, if it is a viral infection, if suspected viral infections, if the child is doing well, feeding well, no fever, there is no need to start an antibiotics. There is no need to start.
Sir, when you make a diagnosis of pneumonia on the case sheet, I think better start antibiotics.
Yes.
Because if you make any other diagnosis, you can discuss like that.
Definitely.
Because now, even though we know viral pneumonia, we bound to start antibiotics because so many reasons
Yes,
also.
sir. Yes.
We don't know how the small child get aspirate, developing some wheeze also.
Definitely.
I think in this ground, a pneumonia antibiotic is a must.
Yeah, so if we've made a diagnosis of pneumonia or we've gotten an X-ray done and shown a pneumonia, then we have to prescribe an antibiotic. If we've just made a diagnosis of a wheeze-associated lower respiratory infection, we'll not get an X-ray also in that child, we'll just manage. If the child is not responding and we get an X-ray and we show a pneumonia, then we have to write an antibiotic.
Yes, Dr. Gaurav. So continuing with that only, I just want to say there's a growing fear of PBP,
protected bronchial.
So that is an
bronchitis.
entirely
So-
different panel discussion
no,
in
no,
itself.
No, what I mean to say, that's why people are saying that if you have got a strong suspicion for bacterial lower respiratory infections, then the antibiotic course should be at least for 2 weeks and not for 7 days.
No, sir.
If you are suspecting more
The
of a viral,
guideline is
then
clear.
maybe
No,
7
sir.
days.
The guideline is clear. For our community-acquired pneumonias, 7 days is more than enough. PBB might be getting a little overdiagnosed as well, if I may take the liberty to say that. But
There's a
that's a
going
totally
fair for
different presentation, sir. 4 weeks
That
of
is
a
the
rattling
difference.
chest and a wet
PBB is
cough.
to prevent the developing PBB.
We'll not go to the PBB part, sir. I'm sorry.
PBB is different, sir. PBB is cough for more than 20 days, 25 days, and the typical type of cough. That is the PBB.
Sir, we'll wind up
I'm
with
not
this last
talking of
question.
PBB,
Sir, I'm
it's-
sorry I'm interfering. Last question, we'll wind up.
This is basically to get a clear message from the panelists here. These days we find that a lot of prescriptions are used for oseltamivir. Now, I would request the panelists to give us a very clear message where to use it.
Oseltamivir, sir. The final word.
Actually, it is a controversial thing, and many times we are tempted to use this, especially if you are suspecting viral pneumonia and the baby is sick and not responding. We have to start. We have to start, especially in small infants. We may have to give that. Otherwise, our experience in using the antiviral drugs is limited so far. So nowadays it is available, but we don't venture on using antiviral drugs unnecessarily.
So,
Sir, I think
sir, we
have to wind
run out
up
of
now.
time, sir.
For
Thank you.
oseltamivir, one line. The oseltamivir is indicated if there is an ongoing epidemic, number one. Number two, if you have done a flu testing and if it is positive. Otherwise, indiscriminate use will also give rise to antiviral resistance. 3 lines. Over from that.
Thank you, sir.
Beautifully answered. Thank you
for
very
the
much.
wonderful
Thank you to the
discussion.
audience.